Welcome to the Roetzel HealthLaw HotSpot. HealthLaw HotSpot is a podcast for physicians and health professionals that covers the legal issues and trends that affect the healthcare industry.
Hi, everyone. Welcome to the HealthLaw HotSpot. I'm Ericka Adler, shareholder at Roetzel and Andrus and leader of our healthcare practice. And today I'm joined by my colleague, Christina Kuta, an invaluable member of my HealthLaw team. And today we're going to be talking about something that has garnered many phone calls and emails in the past couple of weeks. And this is the No Surprises Act, which became effective January 1, 2022. So we hope to give you some of the information that you may be looking for and to give you a better picture of what your obligations might be, what you should be doing within your practice to be on top of it, and then hopefully answering some of those questions that you might have once you look into it a little further. So thanks, Christina, for making the time to come talk with me today.
Of course, happy to be here.
All right, so now from what I understand, there are two major parts of this act that we are most concerned about. But today we're going to be talking about the good faith estimate part. But why don't you just give us a little bit of a rundown on the two major portions that could apply to physician practices, and then we'll kind of get into detail on the good faith estimate piece.
Sure. So the first part is what is commonly referred to as the balanced billing provisions. And this is really a situation where a patient shows up for emergency care in like an emergency room, emergency department of a hospital, or a patient receives services in an in-network facility, but the providers providing services to that patient in the facility are essentially deemed out of network. In this instance, there were concerns by the government that patients were receiving bills, some paid at out-of-network rates, which required a lot more out-of-pocket cost and expense to the patients, and then the actual facility bill would be an in-network rate. So to sort of eliminate the surprise billing, the government essentially said that in the instances where someone goes for emergency care or in an in-network facility, but treated by out-of-network providers, they are only required to pay what generally would have been in-network rates. So the amount the insurance company pays to the provider then can't what we call balance bill the patient for its charges minus what they receive from the insurer. Generally, this is not going to impact many of our private practice physician groups or dental groups because they don't fall under the circumstances where the balance billing applies. But it is important to know if you're a hospital-based provider and are providing services under contract with the hospital or an emergency physician practice group that's staffing an emergency facility under contract with the hospital and you are not in network, that these particular balance billing provisions may apply to you.
Okay, now I know there's a couple of exceptions to this. One would be if there's an emergency, you might actually, not be able. Well, why don't you explain what happens in the event of an emergency? Let me put it to you, and then are there any situations where you can balance bill? Put
Sure.
it out there like that.
So in an emergent situation, again, if you're going to an emergency room for an emergent service, the balance billing acts do apply and you can't be balance billed for the service. However, there are some exceptions, and that is the patient gives active informed consent to receive services from an out-of-network provider in a network facility, and there are only certain out-of-network providers that this might apply to. But if the patient actively provides informed consent and is capable of doing so, then that provider may be able in that instance to get around the balance billing provisions and actually balance bill the patient as an out-of-network provider.
Right. I would assume that would come up where patients given a choice as to what facility they want to go to, and then perhaps their physician might say, in that limited circumstance, I am not in network, to provide services there. If you want to proceed, please sign this consent or something like that, right?
Yeah, it would be in instances where a patient is actually given a choice and understands that they have that option and have that choice. In instances where there is no choice for the patient, they would have to use an out-of-network provider at that facility, then the balance billing provisions would apply.
Right. So I guess like if you go to a facility and you choose it because it's in network, you don't know who your radiologist is going to be. You don't know, who the anesthesiologist is going to be. And so if you got a bill that wasn't in network, you'd be pretty surprised. And I think that's really what the initial goal was in drawing up these regulations to kind of make it more fair, because, this is not, when you choose your facility, you expect everybody working there to kind of be in network. And that's kind of where they came from on this.
Absolutely. And many states had already sort of addressed this with state regulations. Illinois has sort of a balanced billing provision it's had for a number of years that's similar to the now federal law. And I think the government sort of saw some disparity between the states and at least wanted a level playing field for everybody, with a minimal requirement that balanced billing couldn't happen. And it really presents a floor and not a ceiling. So if a state law has something that's more restrictive, that state law would apply in a more restrictive instance.
Okay, great. All right. So if anybody has questions about that, we can definitely answer them. But I think what most of our clients are really interested in is this new good faith estimate portion of the law that has gone into effect, and many of them are unprepared and unfamiliar. So we really kind of want to give you a little bit of background and talk about some of the questions that are out there about how this will apply and some of the nuances. So why don't you give us a little bit of background to get us started?
Sure. So the good faith estimate portion of the No Surprises Act essentially requires providers, and this isn't just the emergency contacts or we talked about out of network versus in network. These are all healthcare providers. So this is going to apply to private practice dentists, private practice physicians, physical therapy practices, mental health therapy practices, etc. And essentially it requires that each uninsured patient receive a good faith estimate of what the services they're requesting might cost. And uninsured patients essentially means patients that have no insurance, or patients that have out of network coverage only that's not going to cover the procedure, or patients that choose not to use their insurance at all. They may have insurance, but say for this procedure, I don't want to use it. And we'll talk a little bit later about what physician practices and dental practices sort of need to consider when a patient has insurance and says, I don't want to use it. But those are the instances where the good faith estimate applies, or when a patient specifically requests a good faith estimate. And when they do, there has to be a written notification that has a number of requirements. The name of the provider, the service, providers identifying information, dates of service, estimated cost. There's some disclaimer information that needs to be on the notice. So it's not just a matter of you telling the patient, okay, we think it's going to cost $100 and that's it. There's a pretty formulaic document that needs to be provided. And in practice, there needs to be a template that's sort of developed that hits all the information that the law requires to be provided. That needs to be provided within 3 days of a request by a patient. When patients call to schedule a procedure, the practice does need to inquire if they have insurance or that will cover the service, or will be using insurance that will cover the service. And if the procedure is within 3 days of when the patient's calling to schedule, the good faith estimate has to go out within 1 business day. If the procedure is 10 days or later, then it has to go out within 3 business days. Upon patient request, the patient has to receive it within 3 business days.
Okay, now can they receive it via email or portal, or does it have to be in the mail?
Sure, great question. They have to receive it in writing. So verbally, they can be told what it is that the patient requests over the phone, that's fine, but they have to receive in writing. It could be an email, it could be in written format handed to the patient or mailed to the patient. It really is whatever the patient requests, the practice should comply with. Also, practices must put this on their website, the good faith, the requirement and ability to receive a good faith notice. So it's prominent and patients are able to see it if they review the website.
Okay, so if patients are going on the website, do they need to also post this in their offices, kind of like the HIPAA discussions we used to have?
Yes, they should be posted in offices where scheduling occurs or where patients may actually ask about bills or costs. So maybe you have like a billing office in your practice where a patient may talk with someone to say, how much would something cost? It should be posted there as well. Also, if you provide anything electronic to a patient, let's say they want something emailed to them, or they want the good faith estimate sent through a patient portal, they have to be able to save and or print that good faith estimate. So you can't send it in a way that's locked. The patient couldn't save it or couldn't print it.
Okay, so 2 things I understand here. One is that we need to let patients know about this law and that we intend to comply with it. So that's the first thing all our practices should be doing, putting these requirements up on the website, making sure patients know they can ask for and will receive this good faith estimate, and making it available in the office or wherever, however they're going to share that information. Second thing is when patients call, they're going to find out what type of insurance they plan to use to see if this applies to them, and then reiterate, their intention to comply with the law. And then the third thing that you kind of covered there is that we literally need to give them this good faith estimate within a certain amount of time, and that it must have some components in it that are very specific. So to dive into this a little bit more detail, and you and I have talked about this, is that it's really hard for providers to kind of know what to put in that estimate. An estimate is just an estimate. I mean, as a lawyer, we're asked all the time to estimate, and things happen. So this is what I think is the most important thing, is that providers need to know that you can update and change this estimate. There's no limitation that I'm aware of on the number of times you could change it. If new services are requested, more visits are requested, the patient's medical condition changes, something costs more, you need to provide them with something that you didn't anticipate, there needs to be a constant updating of this good faith estimate, and always inserting that into the medical record. And so this is really, it creates definitely a burden, but it is very doable. And I think only time will tell how this is going to work out. But practices really need to make it part of their ongoing preparation for every patient visit. Mary's coming in. What is Mary coming in for? What kinds of things could come up? Like, I guess the broader the estimate, it's better to overestimate, I guess, than underestimate is what I'm saying. And you really need to stay on top of this. Could be quite a lot of paperwork and preparation. Am I understanding the law properly?
You are. And in fact, the good faith estimate notice requirement says that you actually must tell patients this is only an estimate. There may be additional items or services that are required that would be added to that estimate, and that the estimate is subject to change anytime. It is not like a binding contract between you, the provider, and the actual patient. But you are understanding it correctly. There's a lot of documentation that needs to happen here, and a lot of training that's going to need to happen with office staff, particularly people that are doing the scheduling. Oftentimes when you have a procedure, your provider will send you to a scheduler or someone that works on making sure that they set you up with the time when a procedure is happening, when a service is happening. Those people need to be aware that they need to ask about the insurance status, if the patient's going to use the insurance, look at the dates for when that service is actually going to be provided, to assume and hope that they get the notice in appropriately within the required timeframes. So this is going to take some office administration and probably a little bit of repetition and training for people who are working in the practice in these types of areas to make sure this is happening smoothly. The good thing is you can probably use a template notice and just change information that's patient specific. So once you have the documents crafted and once you have your process together, it probably will seem like second nature, but it is going to take a little bit of time for everyone to ramp up and get to that part.
Right. So I guess if you have like a checklist of the most common services you provide, maybe you can be checking off the ones that the patient's coming in for and what the cost associated with it is. And if you know there's potential that in the middle of a patient visit that, for example, if you're doing a derm visit, you might have a fee for, looking over the patient's body. But let's say you notice a mole or something and you want to remove it, you'd want to make sure in that estimate that you include an estimate, per mole removed or something like that, because you don't know what could happen. Now, the reason this is so important is that my understanding is that if the estimate is not accurate within a certain dollar amount, that a patient can avoid paying that extra amount, by which the actual fees exceed the estimate. So, am I correct about that? And, what else can you tell us?
Yeah, you are correct. There is a dispute process. And if the estimate is over $400 from what the patient's actually been charged, the patient can dispute that. And there is concern, in the medical community that the sort of preference and the way that the dispute process might lean is in the favor of the patient. After all, this is the No Surprises Act. The patients are getting these good faith estimates to avoid surprises in bills. So if there is that much of a disparity between what they're charged and what they actually were quoted on the estimate, there may be a likelihood that the patient does not have to pay that overage amount. I think it's important for providers, though, to understand that if there are additional charges that happened because they started a procedure or started a service and something happened they could not have anticipated or couldn't have recognized and really provided a good faith estimate, that those likely and hopefully will be valid reasons that an estimate might actually differ from what a patient is charged. I mean, the provider's charged with acting in good faith in providing these estimates, but there's certainly things that may occur or pop up that they could not have known about or are more detailed, or the process takes more time or more effort, and that might legitimize these additional charges over and above what was given as part of the good faith estimate.
Right. And I think so a couple more things here. One is that if you provide ongoing services, you need to update your good faith estimate annually, correct? So it might be like a patient who comes in for therapy once a week, all year long, and you need to update the good faith estimate with that patient. The second thing I want to kind of clarify is that, and you mentioned it already, that this is an estimate. But a lot of doctors, particularly ones who do procedures or more, cosmetic work, I know this will be the kind of thing they do. They literally sign a patient contract as well. So this is not intended to replace that. You do want to have both and continue to have both, correct?
Absolutely. And again, as I noted earlier, the good faith estimate requires that you say this is not a contract. So anything that you're doing now as a contractual requirement with your patients, you'll want to still do and not have this stop that process. This is just an additional requirement as of this year.
Okay. What about emergency services? So somebody calls and says, I'm not feeling well. Can I come in today? What do we do with patients like that?
So it's interesting. There's a little bit of a debate and there's no clear guidance yet. Hopefully there will be in the near future as people start working through this. Essentially, the regulations state that if a procedure is within 3 days, you have to 1 business day to provide the good faith estimate. And if a patient requests, then you have the 3-day period and the 3-day period if it's at least 10 days out. But in a situation where someone comes in today or tomorrow, is there an obligation to get a good faith estimate? And some people have read the regulations to say no, in those instances there isn't. And that would make some sense because it would be difficult for a provider in that instance to sort of estimate quickly what that service might cost in a more emergent situation. But there are other people that have reviewed it and said, the overall regulations and some of the discussion surrounding the regulations essentially says if you're uninsured and you want an estimate, then you have to be provided with an estimate. So, from a practical perspective, to the extent providers can provide a good faith estimate, even if it's someone who's coming in the next day, it just might be better to cover all your bases and do that if you're able to. Hopefully there'll be some more guidance in the future on how services that are provided or scheduled within that 1 or 2 day period, but before 3 days actually should be handled.
Right. I mean, and it's really hard to know. I think practices really just need to think about their intake procedures. I mean, patients check in at the front desk, and no matter whether it's a same day appointment or they're making their next appointment, there needs to be a process to make sure that these boxes are getting checked. And unfortunately, healthcare practitioners are already under such an, overwhelming administrative burden that, despite the best efforts that the government had in putting these into place, this is just creating more burden, more paperwork. We've already got some manpower issues in many practices right now. And this is, just another piece of it. So it is rather, difficult. So a couple of things I want to ask you about. One of them is that right now, as you mentioned, this is going to be for the self-pay and uninsured. But I understand that this may be expanded. Is that correct?
Yeah. So beginning with next year, there is an expectation this might be expanded to actual insured patients and not just the uninsured patients choosing not to use their insurance. There's been some pushback on that in the relevant community, and I think that's still sort of being debated on what the regulations would be and how that might work. But that is an expectation. Also, starting next year, the good faith estimate will need to also provide a good faith estimate of co-provider services. So if you have a service or a procedure where you may have another provider that's going to be involved, let's say a laboratory is going to have to do labs or pathology or something related to a procedure, that co-provider would need to provide information to the primary provider, estimating their costs and what their fees might be to the patient, and that needs to be included in the good faith estimate. Not something to worry about right now. It's not in effect, but it's going to be in fact January 1, 2023. So as the year marches forward, it's something to prepare for.
Right, and that's really going to impact making sure that practices have really clear communication or contracts with these co-providers that they do business with, because you can't, be contacting the co-provider on every patient to find out what their fees might be. You need to kind of have that set fee schedule so that you can estimate. And then I would also assume that to the extent the patient later complains that the actual costs were greater than the estimate, that the practice would want to hold that co-provider responsible if it was, as a result of faulty information that they provided or something like that. So it's a lot to think about.
Sure, and the interplay of how that might work if a co-provider gives a good faith estimate that's just extraordinarily off and really wasn't in good faith, and how that works interplayed with the provider who had to provide that estimate with that information will be interesting to see. I feel like it's going to be subject to dispute and debate for sure.
Right, and I mean, I feel bad for providers that not only are going to have to go through this administrative hassle, but then work out their deals with co-providers, spend the time, effort, lawyer fees, whatever it may be. And then on top of it, down the road, find themselves having to deal with patient challenges, which again is another time and money consuming possibility as a result of this law. So, it's so important to get this right, from the start. So a couple more things I want to talk about. First of all, let's talk about enforcement. Who's enforcing this? Are they enforcing right now? What can we expect for those that, put this on the back burner and don't do it?
Sure. So right now, I don't think there's been any real enforcement. It is so new, and hopefully there will be ramp up time and sort of forgiveness time as people are trying to go ahead and pursue these requirements in good faith. You spoke a little bit earlier. One of the ramifications if you don't comply is the patient may not have to pay their bill. That's certainly one ramification. Also, there's a possibility that there could be civil monetary penalties, which could be $10,000 per occurrence, that could be attached to this if you're not complying with the law. So there can really be some financial consequences. Also, there could be an event where the government wants to enter into a consent agreement or some form of formal document that's publicly available that says you haven't been doing what you're supposed to do. You're now going to comply. You'll comply within this time frame. This is where you're going to need to do, et cetera, signed by the provider, signed by the government, and that is something that's publicly available. So to the extent you don't want people to see that you weren't doing what you were supposed to do, that can be problematic as well.
Right. Okay. So we really, you're going to either suffer if you have to do it, but you might suffer more if you don't do it. So you kind of weigh those two possibilities. I think eventually, everybody's got to come into compliance. It may take some time. So a couple of other things, and you mentioned this earlier, which is how does this apply when you're asking a patient, if they have insurance and they don't want to use their insurance? So one thing I know for sure is that if you're, a patient that has some federal source of payment like Medicare, et cetera, that you are not supposed to be waiving that. But why don't you speak to how it applies to both like Medicare, Medicaid, et cetera, and other types of commercial insurance?
Sure. So if you're a Medicare provider, for example, you're required to bill Medicare. You can't just allow the patient to pay out of pocket for the service. Similarly, with commercial insurances, most providers enter into written provider agreements to be a participating provider in an insurance product. And oftentimes, those agreements do say that you are contractually obligated to bill the provider for any beneficiary that has coverage for the procedure or service you're providing. So it actually may be a violation of your insurance contract if you allow a patient who has insurance to go ahead and pay out of pocket for a service. So that might be something providers need to consider and have their insurance contracts reviewed, generally just to see what the terms and conditions are related to that. Also, you can't stop a patient from being dishonest or lying and saying they don't have insurance when they really do. For certain insurance products, and I think certain federal payers and state payers, you actually can sort of look up if the patient has insurance, but assuming that's not reasonable or you can't do that, I think you need to make it clear to the patient that they have to tell you if they have insurance and perhaps have them sign something either electronically or when they come in with the general consents and other forms that you're providing, that they are attesting on that document that they do not have any insurance.
Okay.
That would cover the service.
I guess, to be safe, although it might be burdensome, but sometimes maybe easier is just perhaps having the same process for everybody. So regardless of somebody saying they have insurance or don't have insurance, plan to use their insurance, etc., it could be a safer approach to just give everybody a good faith estimate, and then you're covered no matter what. But obviously, it really depends on the practice. We have a lot of practices, whether it's dental or certain types of, more selective types of services, maybe cosmetic, etc., where almost all the patients are cash. Right? So we know that these are the type of practices that must do this. For other practices where you mostly would use your insurance, they're going to have maybe less of a burden. So, I mean, you can correct me if I'm wrong, but I would assume that, a lot of patients going to like OB-GYN, for example, are using insurance. They're not saying, oh, I want to pay you cash. So that could be completely wrong. But in those type of practices, I would expect to see fewer patients kind of electing to pay cash or not to use their insurance. So it's definitely going to hit certain types of practices more than others. So I hope those are the ones particularly paying attention. And of course, where does number one source of practices getting in trouble come from, Christina? Comes from
other practices,
but also who complains? Patients, right? So you get those patients who go to one doctor's office and they got a good faith estimate, but then they come to yours and there's no sign posted. You didn't talk to them about it. You didn't ask them the question. So Christina and I know from experience that when practices are getting in trouble, whether it's insurance, whether it's complying with the law, even we saw this with vaccinations and COVID and masking, etc. The number one source of complaints are patients. So, it's not one of those things you're going to be able to just get away with because nobody knows. Sure. So keep that in mind.
And two, we don't expect patients to know all the little nuances of this law, right? So they may go to a provider and they may absolutely have no insurance coverage for the procedure they received at that provider service. So that's why they got the good faith estimate. But they go to a different provider and they absolutely have insurance coverage for that. But all they see is, wait, you didn't tell me how it was going to cost here. Well, that second provider wasn't required to do that. So, I mean, there is going to be some level of education, I think. And I think it's important, again, for the practices to be educated. So if patients do have questions, they're able to answer them appropriately and reasonably to try to avoid some of those potential complaints or potential issues where patients think they're not being treated appropriately, but they really are.
Right. Absolutely. All right. So hopefully we've covered all the essential points that we want our practices to know about. And of course, call and ask us questions. We can't possibly cover every nuances out there. But is there anything else you want to add that you want people to be aware of that we haven't mentioned?
I would say that the government has put forth some template documents regarding notices. If practices want to start putting something together, they may be able to use that as a starting point or a base, but it's always better to sort of tailor documents to your practice, your particular practice needs. So, certainly I would recommend that practices have any notice they put together reviewed by legal counsel just to make sure they're complying with all the laws. But there are templates they can look at to, start the process.
Okay, great. And of course, if anyone has questions, feel free to contact us. We're happy to help. In that case, we'll sign off. So this has been the HealthLaw Hotspot. Thanks to Christina Kuta and joining me today. If you have any questions, let us know. You can also see all of our other podcasts at ralaw.com. And we'll see you next time. Thanks for joining us.
The Roetzel HealthLaw Hotspot is made available by the firm and its attorneys for educational purposes and to provide general information, not to provide specific legal advice. Use of the Roetzel HealthLaw Hotspot does not create an attorney-client relationship between you and the firm or any of its attorneys. The Roetzel HealthLaw Hotspot should not be used as a substitute for competent legal advice, and you should contact an attorney in your state about any legal needs or questions you may have.